Let's get started. So, thank you everyone so much for coming today, and thank you to AMERSA for hosting this conversation. Today is our second webinar in our AMERSA advocacy series on methadone reform. If you haven't had a chance to watch webinar one, Christy's going to drop the link in the chat. Please take a moment or an hour to watch that. It provides helpful background for our current discussion. For today, I should note that we are starting from a shared assumption, which is that methadone reform, things like expanding take homes, telehealth, mobile dosing, and individualized patient centered practices, is broadly a good thing. We are not here to debate whether these types of reforms matter or really to debate anything at all, but rather we're here to discuss how those reforms actually get implemented in the real world. As a reminder, if you missed webinar one, methadone regulation operates at multiple levels: federal, state, and clinic. Federal officials set the limit of how flexible methadone regulations are in this country, and states can choose whether or not to adopt those flexibilities or maintain stricter rules. And then clinics or opioid treatment programs themselves can choose the same: adopt and incorporate those flexibilities or maintain stricter practices. So then, by design, a change at one level does not necessarily translate into a change at another. To read more on this, please see the AMERSA position statement led by Dr. Leslie Swen, as Christy drops that link into the chat as well. So this gap between policy and practice is where a lot of innovation and leadership is witnessed, but also a lot of frustration and tension. We chose Colorado as our focus today because it is a state that has genuinely moved the needle in the realm of methadone reform. Colorado has expanded OTPs statewide, increased methadone enrollment by over 40% between 2017 and 2022, and importantly, has made formal changes to state rules to better support evidence-based, patient-centered care. That kind of state-level rule change is rare and worth examining closely. At the same time, progress looks and feels different depending on where you sit. From a state perspective, regulatory change is slow and complex, and if and when it finally happens, it feels like a hard-won victory. But from a patient perspective, a change on paper may be meaningful, but still feel wholly insufficient and inconsistently applied. From inside a clinic, pushing for practice change often means balancing patient needs with staffing constraints, burnout, and concerns about risk and compliance. Today's conversation is about those realities. What does methadone reform look like and feel like at the state level, the clinic level, and the patient level? Where has implementation worked? Where has it stalled? And what can others learn from Colorado's experience? So we are going to have about a 45-minute discussion and aim to leave 10 to 15 minutes for audience questions. Please make a note of what you'd like to ask our guests and save those questions for the end. So let's begin. I'd like to start by inviting our esteemed panelists to briefly introduce themselves. Gentlemen, please start with your name, your role, and your connection to methadone reform and implementation in Colorado. We'll begin with Andrew, followed by Paul, and then Ryan.
Thank you, Rachel. Hi, everyone. My name is Andrew Goodman. I'm a community navigator with the Department of Public Health and Environment in Denver, Colorado. I grew up in Edwards, Colorado, but have been in Denver since around 2009 or so. Today, I will be speaking in my capacity as a patient advocate and board member at the National Coalition to Liberate Methadone, and I have been on methadone for the last 10 years.
Awesome. Thanks. I think I'm next. Rachel, thank you for the introduction. I'm Paul Christine. I'm an internal medicine and addiction medicine physician at the University of Colorado and at Denver Health, which is the large safety net health system in Denver. I provide integrated primary care and addiction care, including integrated methadone into primary care at one of our federally qualified health centers. And so I'm primarily going to be wearing the hat of somebody, a clinician who works in the methadone treatment system. I'm also a health services and policy researcher interested in methadone policy and policy implementation. So I look forward to this, and I'm grateful to have the chance to talk with Ryan and Andrew here, who are both good friends. So.
Well, good afternoon, everyone, and it is an honor to be here on this panel with you all. My name is Ryan Mueller, he, him pronouns, State Opioid Treatment Authority, and Associate Director of Controlled Substance Licensing at the Behavioral Health Administration in Colorado. It's a lot of words, but essentially what I do is help to regulate methadone clinics and withdrawal management facilities in the state, and also advocate for regulatorily or legislatively or otherwise the expansion of quality access to treatment for opioid use disorder. My connection to methadone implementation here is on the regulatory side, drafting and stakeholdering with our communities these rules, and eventually working towards publication, then training and enforcing OTPs, enforcing these rules with OTPs and our providers in the community. So happy to be here.
Great. Thank you all. So we've run the gamut here. So let's get going. This question is to all three of you, and whoever feels the urge to begin may do so. From your vantage point, how would you describe the current state of methadone reform implementation in Colorado? Where do you feel the state has come from, and where are you trying to go next?
Yeah, I'm happy to start. Colorado has made real meaningful progress, especially compared to where we were even a few years ago. Federal changes to 42 CFR Part 8 and corresponding state updates have reduced some of the more Kafka-esque barriers. And for many patients, daily life is genuinely easier. That being said, though, implementation is uneven. The reforms exist on paper, but patients' lived experience still depends heavily on which clinic they attend. Where we're trying to go next is probably closing the gap between the spirit of the reform and the actual implementation, ensuring that increased clinician discretion, individualized care, and patient agency are actually realized in practice.
Thank you, Andrew. I'm going to recommend Paul and Ryan just stay off mute. You can do whatever you want, but get in there.
I'll be curious to hear what Ryan has to say, but I think I agree with Andrew. We're sort of like, I'd say we're kind of in like a middle stage right now. I think we've made real progress, and I want to acknowledge Ryan and his team, which the state has essentially adopted the federal regulations sort of whole cloth, and without that, no changes would be happening. But I agree with Andrew. We don't have a great sense of what's happening on the ground, and I can say even for my own clinic, implementation is challenging, and I do think the next step is really with the clinics, both in terms of a holistic understanding of what is going on, who's made changes, who hasn't, what are the pain points, so that we can help people do these things. So, but curious what Ryan has to say.
Well, gosh, I didn't know we were going to agree this much, gentlemen. But I guess for a little bit of background for folks, opioids, throughout the history of our species and our relationship with them, we've sort of, depending on these forces, it's how opioids may impact a society. And that is the power of the drug itself, the demand from the public to use those medications or drugs, the influence of those who stand to make a profit, and government intervention. Sometimes those concepts are very intertwined. And in our nation's history, can anyone on this call agree that we've mapped out a perfect map for how to handle opioids even in 2026? I don't think we can. So we've always sort of struck this uncomfortable balance with utilizing an opioid to treat opioid use disorder. And a lot of that has been built upon lack of trust and stigma towards the disease, but also the treatment of the disease. But over the past 5 years, no question about it, we've had some pretty dramatic changes in regulatory reform that we believe have certainly impacted considerable census expansion and OTP expansion. And we have to call out also that we are beginning to see considerable declines in opioid overdoses and overdose deaths. That is not to diminish the amount of pain and suffering that is occurring now in our community. We still are at a public crisis point when it comes to opioid overdose and overdose deaths and its impact in our community. But we think we're moving in the right direction. When it comes to where this goes next and what has to happen, I agree wholeheartedly that it's easier to make those changes on paper, but to get everyone sort of marching, singing in the right direction into contemporary practice is certainly going to be a focus. And I don't know if we're going to talk about this later on, but I might just say here that we've got some amazing OTP providers in our community, in our states. And it is important to call out that this relationship with partners and regulators has been strained for a long time. Remember, that lack of trust was sort of built into the system. So if you want to create a program, you have to build it with that fear, with those really strict guidelines. And just because we relax some of those guidelines doesn't mean that the culture suddenly thaws and people feel comfortable stepping into that space. So anyway, I totally agree that that's where this goes next, is education and time and partnership.
Yeah. Thank you all. So there seems to be consensus that the state of methadone reform implementation in Colorado has moved forward in a necessary but insufficient manner. And also something I want to highlight that was sort of brought to light in preparations for this webinar is, what do we even mean by implementation? Do we mean changing the regulations themselves, which could take years? Do we mean the actual dosing on the ground, for example? And so let's get into some of those specifics. And let's start with something good, just to set us off on the right foot. Some good news.
Okay, good news.
Can one of you share, maybe you, Ryan, hold your horses, a concrete implementation win? Something in Colorado that is different, that has worked better than expected, or at least a moment where change has really taken hold in practice?
I think we can do that.
Okay.
First and foremost, let's start with that regulatory reform because
Yeah.
it's official. It's the rule of the land now, and we're able to lean into it. But we're also beginning to see some real change. Remember, our office also has to audit these facilities. We go in and we have professional long-term relationships with these people, and we have to relicense them based on their ability to maintain substantial compliance to these regulations. And what we are seeing as part of this regulatory reform is providers beginning to induct patients on higher doses of methadone coming into the program, which ultimately is better at addressing withdrawal symptoms, which is more likely to keep people retained in treatment and more likely to build treatment census. We are seeing take homes begin to thaw out a little bit. And when we say that, for those on the call that are not sure what we mean when we say medication self-administered at home or take homes, for the longest time, it was the requirements of the FDA and ultimately SAMHSA and each state to keep take-home medications, methadone take-homes, to very strict scheduling. And you had to meet a federal standard and sometimes more aggressive state standards in order to receive those medications. And more recently, in federal change, and in our case, Colorado change, we have relaxed some of those limitations to allow prescribers to make best decisions individually with their patients. And as a result, we believe we are seeing more take-homes being provided to individuals. And we are also seeing, as a result, we believe, far less administrative discharging of individuals. So we're asking clinics, remember that old way of doing things where you had to really care for that perfect patient who could follow all the rules. And if they couldn't follow the rules, then they were going to get your clinic into hot water with regulators. That is a very different philosophy now, that we don't carry that. And we say, listen, meet people where they're at. And we understand that not everyone is going to fit into this perfectly well-defined box. And we want to give you more space to be flexible. We have also seen, got to call it out, OTPs went from 25 OTPs across our state to 53 in 5 years. We went from 6,500 patients up to 10,000. We are seeing retention efforts begin to rise. The University of Colorado just put out a preliminary study sort of looking at post and pre Part 8 changes. What's their retention look like? And they're beginning to see that patients are staying longer in treatment than before. It's also worth noting that OTPs are now up in 30% more counties than they were before. So It's my opinion, a strong opinion that this expanded access to treatment has, in the at least initial stages, we can argue has resulted in a decrease of opioid-related overdose deaths. So I will pass it off to my colleagues.
Okay, yeah, beat that, Andrew and Paul. Any other concrete wins that Ryan hasn't covered? What have you seen or felt in your day-to-day experience in terms of wins? We'll get to areas to improve later.
I'll just keep going in the middle here. I think just something concrete that's been maybe a little surprising, and I'd be curious from other folks on this call what their experiences are in different states, but it's been a range of OTPs that have made some really made changes that are really consistent with the new federal regs. And so that can range anything from like our nice like boutique academic OTP, which is often more progressive in its dosing and take-home policies, but to private equity-owned large chains. And in particular, like I think the dosing changes have been readily adopted. People were ready for that. They were chomping at the bit to start higher. And telemedicine, maybe sort of, at least for me, maybe a little underappreciated component of the federal changes, I think has really enabled what Ryan mentioned was a lot of expansion of OTPs in the state. So including in rural areas that did not previously have access. So chains opening up dosing units or satellite clinics in rural areas and using telemedicine to help staff those clinics in a way that I do think has really expanded access. I'll pass it to Andrew.
Yeah, I would really echo what both of them just said. Tangible wins, there's a 24-hour open OTP now in Denver. They mentioned higher starting doses and faster induction. The move to the more access in rural communities, that's big for me. I grew up in a small ski town and was prescribed different formulations of buprenorphine over and over again, Vivitrol of the other two FDA approved MOUDs, but never methadone because I'm white, middle class, and from a rural community. So I think that's a huge win in and of itself. And then another one is, I know that Ryan changed within Colorado regulations the definition of stability to include things outside just your UA charts, and I think that's a huge step in the right direction.
Can you say a little bit more about that, Andrew? What does that mean in practice? What does it mean, this definition of stability, and why is it important?
So we'll get my caveat of where these things fall short comes next.
Okay.
But I think just expressly to have the definition change, and so that they can go in and say, we're not just looking at your UA results, we're looking at outcomes that are important to you. Ideally, they'd be looking at outcomes that are important to the patient, employment, social stability, those type of things.
Got it.
And then my last
Not
win
just
would be
what's in your urine. Okay.
Exactly. And then last win would just be this collaboration, conversation between different stakeholders. I think this was missing, and I'll touch on it a bit more later in the panel. But yeah, I think that this is a huge step forward in and of itself, and leads to research partnerships, better survey outcomes, where if you're just getting a provider perspective and not the patient perspective, you're missing half the story.
Okay, cool. So there's more appetite for patient perspective.
A little bit, yes.
All right. Okay, Ryan, back to you. And this one really is directly to you. Many people hear that a state changed the rules and imagine something that feels like a relatively straightforward process. Since most of us on this call today are not in state rulemaking, at least not to the extent you are, can you please walk us through at a high level, talk to us like we're five. What does it actually take to formally make methadone-related rule changes at a state level? And which parts of that process are the hardest for folks to typically understand who are outside of government?
Wow. If you told my 16-year-old punk self that I would be representing government in this answer, I don't know. My head would probably explode. So
Yeah.
I'll try to remember I'm in that role.
Yeah.
But I do think that there's a little bit of luck, but first getting into the space where you can absorb contemporary understanding of the work. And mine comes from experience working with several community centers and ultimately running one of a larger OTP connected to a hospital in our state, and sort of getting that experience of figuring out this. First of all, this work is incredible, and the people that seek services in these facilities are some of the bravest people I've ever met in my life. People having some capacity for survival and improvement in their lives, and in ways that I don't know that I have that strength. And so I was so compelled to stick around and see this sort of work through. But then you start to see, like, why are the rules the way they are, and why are they structured in a way that is so limiting? If this is such a great modality for people, then why can we not make some changes to spread this to other places in the community? Why does it have to be so geographically segregated? Didn't make a lot of sense. And so having sort of that preloaded in the background, and then getting a job at the state and being able to be in a position of rule writing, the next step is convincing my boss that we needed a change. Convincing those that were in those decision-making positions that this was a well worth venture for our state to get involved with. Once that was greenlit, recognizing that I think one of the biggest missteps we've ever made in this field is assuming that regulators know best. And that is just not the way it is. And so the first step was to connect everyone in the community with the rules. So we sat down with providers, we sat down with doctors who did this work, we had roundtables with them, we interviewed peers, people with lived experience that were in these clinics, subject matter experts. We also consulted with leaders and owners of OTPs and ATOD's Colorado chapter, COTOD, for guidance. We also sat down with Medicaid, for that matter, and said, well, how do our rules, how are they not great, and how can they be better? Once they were all in place and we drafted a rule volume we thought made sense, then you have to take that to the legal experts and the rule writing experts that help us look professional and make sure that we don't break anything legislatively. And so that took some time to do. We had to stakeholder these rules across the state, which probably took upwards of a year, and visiting as many counties as we could, both virtually and in person. And then ultimately sitting in front of the state's attorney general and the Human Services State Board to present these changes and to them and the public. Once that was approved, then we had our rules officially published with the Secretary of State. And then that's all what I just described is kind of the easy part. Now comes the harder part, which is implementing and supporting clinics and coaching and teaching and enforcing these requirements to become reality. And that is just a work in progress that I don't think ever ends, but that's sort of at a high level, I think, the best way I would describe it.
Excellent. Thank you. That was helpful. Okay, so now let's get into some of the nitty-gritty. I want to talk about things that maybe looked simple at first glance, but ended up not being so. So let's think about the different levels of oversight, the federal, state, and clinic levels. What was an implementation step that looked simple on paper, but proved much more difficult in practice? And Paul, if it's okay, I'd like to start with you at the clinic level.
Sure. And I think you've already heard this from several of us already, but I really do think that it's underappreciated how much the rubber really hits the pavement with the individual OTPs in terms of these policy changes and practice changes. Many of these clinics have been operating the same way for a very long time, and it's kind of hard to understate that these regulatory changes are big changes for them. And I do think that focusing on sort of organizational change is it is like an overlooked part of this, and it remains a work in progress. And I'll just give an example from our own clinic. Like, we have not adopted all of the regulatory reform sort of whole cloth in the total spirit of, I think, what Andrew is talking about. We still have phases. We still are not able, even as clinicians, to sort of make always make the decisions that I think we feel like are most patient-centered or patient-aligned. And it really is a balance. And I have found that in particular staff there, OTPs are big organizations with a lot of staff that are often underpaid, have a lot of turnover. And for our own staff, I can just say, like, there was a point in time after these regulatory changes, I don't think related to the regulatory changes, but we had so much turnover, we had to like pause intakes briefly and drop our intake numbers. You know, changing these things, getting buy-in from staff at the clinics, particularly if you're in an organization that has a more horizontal leadership structure. It requires some really thoughtful leadership and attention to sort of all the organizational dynamics. And I would love to just wave a wand and say this is what we're doing, but the reality is you will get pushback, and it's not an excuse to not be doing things that are right for patients, but it has been really challenging.
Can I stay on this with you for a second, Paul? What kind of pushback? Is it, oh, you're asking me to do a different job and I don't like change? Is it, I don't think this is morally right?
Yeah.
Is it, our clinic's going to go bankrupt? What's the
I
nature of the pushback?
I haven't heard so much the last one there that we're going to go bankrupt. I mean, and that may depend on the state too. Medicaid here, it's like a bundled payment for methadone care, so we're not
Mm,
necessarily getting reimbursed one off for every single like thing that we do. I will say that there's a lot of I'll tell you a phrase that I've heard is our patients used to get better. And there's this sense that
mm,
patients do not do as well with these, more take homes, for instance. And my sort of rebuttal, also wearing like a research hat, is like, well, if you put the bar to get into the clinic here, like it's going to look a lot different than when we are truly taking a more like harm reduction approach. We're willing to share risk more as a OTP. We're willing to, take on people and continue treatment in circumstances where I think we think it's the right thing to do clinically, but also previously just wouldn't have happened. As
mm.
like Andrew was talking about with sort of co-occurring use of other sedatives, for instance, like alcohol or benzodiazepine. So, yeah, I think there is pushback from people who are like, we've done it this way for a long time. We saw people doing really well. And it's like, well, no shit, you saw people doing really
Yeah.
well because the bar was so high to like get into the clinic to begin with. So,
Hmm.
I don't know if I totally answered your
Some
question,
real
but
selection effects. Yeah, no, that was helpful. Thanks for bring us behind the curtain a bit. Andrew, what about you? What maybe sounded simple when you first heard about these regulatory changes, and then now you're like, what the hell? What happened? It's not happening.
Yeah. So let me just backtrack real quick on the idea of them being afraid that it's going to hit their bottom line. We have to remember that 7 out of 10 people diagnosed with OUD have never been prescribed a medicine for opioid use disorder. So there's missing this huge demographic of potential clientele that if they were just to reduce the barriers, I think a lot of these people would utilize these medications. I know that because at my work at the city, despite this amazing progress, when I'm out doing linkage to care work, I get major pushback and hear the stigma of liquid handcuffs around methadone from people who use drugs, almost more so than anyone else. So if we haven't convinced them that things have changed, I think that's something that we definitely need to do. In terms of where it wasn't as simple, are the regulations working? Yes, they are, and not yet in the ways that matter most to patients. If we take homes, Ryan had mentioned that there's been an uptake in take homes. In my experience, that only goes up until a weekly. And then after that, when it comes, more than a week, bi-weekly or monthly, the rate of people on those, it just drops off. Um, and I think that's because clinics can opt out of the spirit of the reform if not specific regulation changes themselves. So I talk about this loophole. And so we've done this amazing work expanding take homes, and it looks straightforward on paper. but in practice, that collides with clinical level rules, risk aversion, and a deeply embedded culture. So when I go to the powers that be and I say, if a clinic is not living up to these new rules, is there anything we can do? And we talk about, potential enforcement measures. Yes. But at the same time, individual clinics, which a lot of people talk about as fiefdoms, because they're allowed to just opt out of this progress. So they can just, in my understanding, say no to the amazing changes that have been made. So that's where I saw things, not being as simple. The state saying we're going to make take homes more lenient. I didn't understand that a clinic could just come in and say, nope, we're not doing that.
Yeah. Okay, what about you, Ryan? Anything to add here, specifically, maybe building on what Andrew is saying about how the feds set the floor of how flexible you can be, and then, states can opt into meeting that, and same with clinics. Maybe what did you think would be simpler in terms of rollout than what has proved to happen?
Well, I think what I just heard, the wisdom of these two people, I really just agree with it a lot. I would love to add, Paul, you mentioned something that I think is really important to say, and that is that um, really tough regulations just pass along risk aversion down the line. And so they say, clinic, you better be risk averse, so you're going to get nailed. And the clinic says, okay, well, I'm going to only enroll people that are going to not get me in trouble. So if people are really struggling with continued polysubstance use or not showing up to dose, or they experiences overdose often, and some people say, you know what, this is not worth my time. I better not keep you on my census. I don't want to get in trouble. There's a whole lot to say there, but I'll back that up with data. Since these changes, we did a review of our enrollments across programs, and about 41% of our total census right now is experienced its first enrollment with a methadone clinic. And that's pretty remarkable considering, if you understand, in methadone clinics, retention is a real problem. You don't often see people enroll one time and just never drop out. You see people giving it a shot multiple times, even throughout a year. And so to know that 40% of our census are people that have never been enrolled before probably speaks to, hopefully, that invitation for more people to come into programming, which also explains why we went from 6,000 to 10,000 enrolled individuals. So I hope that is understood. And to Andrew's point, I think he's completely right that it is clinic by clinic. And also, I would say that rules, I'd like to think that they are so helpful, because I do the rules, but I recognize there's a limit to that. Rules can't really inform culture to the extent we'd like them to. Culture is informed by a lot of things, community and trust building and time and education. And yes, guardrails have to be there. And we'd like to see that, sort of like, what did Barack Obama say, that progress is not a straight line, but you certainly want to see that it's moving in that general direction. But do we have work to do and room to grow in that? Definitely. And do I see it firsthand when I go to clinics and see them operate culturally different? Absolutely, we do. The one item I might add to this, can I just mix it up? Is that okay?
Sure, get in here.
This is just, this is so confounding. Um, Take homes. So forever, we said, oh, take homes are the way to go. And it's sort of this weird version of contingency management. You show me pro-social behavior and I will give you a reward. And your reward is the gift of time. How about that? Aren't I great? The problem is, with contingency management, you're not supposed to introduce punishment to someone's life. That is not part of the modality. But when you take away someone's take homes, you are in effect causing damage. These people build their lives around their medication access. And when you threaten that, you make them make decisions between taking a life-saving medication or maybe going to their job in the morning, or taking care of their kiddos, or struggling with transportation. And so it's a real mess. And so we recognize you've got to get rid of this old element that people leaned on. But the issue is they leaned on it all the same. And so you have doctors, nurses, program managers, everyone saying, these are the phases, this is the structure, this is the world in which we operate in. But if you take that away, and you ask a clinic to be individualistic about everyone's care needs, well, imagine you have 500 patients and everyone fit into a box, and you were able to manage who got what take home. And suddenly now you have to figure out how you're going to do that individually for 500 patients. I think that is very overwhelming for clinics. And we have gotten that feedback before to say, well, you just took away this system. Well, what did we do in its place? How should we better manage? And I think in some ways, that does give clinics trepidation when it comes to just, would we remove every structure in place, or should we just hold on to this old vestige and maybe try to adapt and make that better as a replacement? So I think there is work to be done in terms of supporting clinics with that guidance. And another element I'm just going to add here is this, that with that old crappy structure, there was still this automation. And when you take that away, how are you caring for things like cultural bias? Because now a provider is able to meet with an individual and make a decision on an individual basis where they should be. Whereas before, that person could lean on those bulleted items and say, I met these requirements. I don't care if culturally I don't align with you and I'm hitting on your biases, you still have to give me these take homes. Whereas now, that might be a little bit different. I'm not saying it's necessarily a problem we've observed, but it sure keeps me awake. And I wonder how we are managing that in particular clinics.
That's a great point, Ryan. Thank you. I think we've heard, I had not made that connection here specifically before, but similar to what we hear with urine drug testing, getting rid of those requirements, checking the PDMP. As soon as you take away a template bullet point standardized roadmap for providers, you introduce the potential of bias and subjectivity. And that is a scary thought. Okay. Andrew, I thought you might have some reactions to some comments. Would you like to build either on stalled implementation or these threads about risk?
Yeah, absolutely. And I love this conversation. I love speaking with Ryan and Paul and other professionals that engage from different perspectives, is because a lot of times I wouldn't take into consideration, and it helps me better advocate. So I always appreciate these conversations. But yeah, so I would just kind of circle back that risk is often assumed, not assessed at these places. So I think what's often lost is that we need to balance the risk of implementing change, like increased take homes, with the risk of not doing so. So for some, including myself, these continued barriers to access have left me like feeling forced to start weaning off my medicine. So I, after 10 years, am reducing pretty quickly because a medicine that has given me stability, allowed me to get through college, regain these relationships. At this point, the barriers feel like the one thing standing in between me and my potential. So I think it's really important to keep in mind that, we can have adverse outcomes by not implementing these changes at the clinic level. Risk, clinical, regulatory, and legal dominates decision making, often crowding out patient well-being. So for instance, like the UAs or counseling, a lot of the times I don't feel like they're about improving patient treatment trajectory. It really is about just compliance. And then that's where, we're Americans trying to seek healthcare, and it starts to feel like a probation department. One example is at a, local OTP, they have cameras in the bathroom. And these are people, trying to get healthcare. And some of them have, experienced sexual assault and have a camera pointed at them. And a lot of times what I'm getting at is I don't think that some of the measures taken are, we want policies that work. We want policies that have good outcomes. And a lot of times I don't think that's what's happening.
Rachel, can I add one
Please.
thing based on, I really appreciate Andrew's comments here. And I feel like it should make us all like angry when we hear somebody who says, I'm on this life-saving medicine, it's worked really well for me, and I'm like considering, tapering off because it's like a barrier to me. That should put alarm bells in all of our heads. The two things I just, about like kind of where has implementation stalled, just to highlight what Ryan has said, and I think Andrew as well, just like, these are highly protocolized environments. They are places where there's a lot of patients who used to come every single day to dose, right? They thrive on protocols. And so asking people to do really thoughtful patient-centered care is very different. And I think involves this like shift in risk. I'll give an example from our clinic, which is not directly related to the regulatory changes, but we've like adopted new restart dosing for people who miss more than 3 doses, 3 days of their medicine. And, like we're putting people back on much higher doses based on our assessment, individualized assessment of their maintenance of opioid tolerance. And I think it's, as somebody who I would think I feel more comfortable prescribing controlled substances than many of my colleagues, but the first few times I did it, I was like, wow, that this feels risky to me. And but I think that's like this is part of it, like before it was just like, nope, drop you to 30 and I don't have to worry about the risk at all for me. Now the person may just quit methadone because it's going to take them a year to get back on their therapeutic dose. So I do think again, it really rests with a lot of the clinics to figure out how do we adapt protocols for these protocolized environments in a way that embraces the spirit of this, but also really can have people get individualized decisions. And I think that does involve like thinking creatively about how do you either incentivize clinics to do that, like carrot or the stick, or how do you from Ryan wearing Ryan's hat, how do you assess what people are doing and give them feedback like, hey, this isn't going to fly.
Yeah. Okay, we are running out of time. Oh my goodness. I would say though, to wrap up this conversation about risk, I think what I'm hearing from all of you is like we are at this precipice where we are asking clinics to choose between risk that is familiar versus unfamiliar and risk that you used to not have to own that now you do have to own. And so owning unfamiliar risk on yourself and your clinic is a big ask. It still may be the right thing to do, but we should at least acknowledge that that's what we're asking clinics to do. Okay, so we need to wrap this up so we can get to questions. I want to do some combinations here. All right. We're going to do, we all come from some type of mental health background here, so we're familiar with the miracle question. If you could go to bed tonight and snap your fingers and change one thing about methadone in your state, but it had to be something realistically achievable in the next few years, can you talk to us about what that would be? And if this is your chance to bring in your final comment, maybe about enforcement or incentivization or risk, now's your chance.
I can start.
Yeah,
Mine's
yeah,
going to be the
you,
least
yes.
interesting. So
Okay, great.
I would say, and this will come as no surprise to anyone who knows me on this call, like one actionable thing that I think could have a big impact is actually just better data on methadone. And so comprehensive statewide data on methadone treatment, dosing, discharges, practice patterns, because that builds more accountability into the system in a way that like we just do not have right now.
Mhm.
That data just, at least in Colorado, does not exist. I know I see Zoe's on here, like Massachusetts has like this lighthouse system they're trying to work, and some other states may have that. But absent that, it's hard to know what clinics are doing, like who, and then hard to figure out how to incentivize them or to discourage them from what they're doing, quite frankly. So that's mine.
Excellent answer. All right, Ryan or Andrew, who's next? I had to teach online earlier today. I'm not afraid to call on people. Okay, Ryan, you go ahead.
I am so appreciative, Paul, that you say that because it's really the real answer. It's very difficult to make an informed decision or have progress on any kind of a problem if you're not managing the data well enough, if you don't really know what you're dealing with. And so I would 100% agree that having a better conceptualization of the data, what is important for us to be understanding, is needed for us to make improvements. But what I will say with what we do know that we think that there's an estimate of 120,000 people in our state that are experiencing an opioid use disorder. And there are, even though we praise that opioid overdose deaths are on the decline, it needs to be known that we have over 1,000 deaths a year attributed to opioids and countless more overdoses that are deeply impactful to people and our community. So we are in a public crisis. Um, I'm going to go somewhere else with this, if that's okay. And that is that I've got some fears, you all. It's not just about improving, but it's also holding this space. I believe that there are other narratives that we sort of have to tangle with that argue that behavioral health care is sort of a failed idea, that substance use disorder is not a legitimate science, treatment is not a legitimate science, and that methadone care is just simply replacing one addiction for another. I think we're kind of a bit in an echo chamber on this call because we always think that's preposterous. We know that this works and we believe in it and we devote our lives to working through it and getting into treatments. But we're here to fight that narrative on every battle line that we can. And so my hope is that over the next couple of years, if that's what we're doing, we're being realistic, is that one, we're holding the line and we're maintaining funding for this in very important treatments. And an important thing to say here is we're talking about regulation like it's the end all be all in some ways. And I honestly think that equitable in payment for this treatment is what is really set our state apart in many ways. We are a Medicaid expansion state. And if you have Medicaid in Colorado, you do not pay for methadone. You do not pay for buprenorphine. That's a huge deal. When I talk to my contemporaries in other states that do not have these similar measures, people have to pay cash. And as a result of people paying cash, you have a lot less interested OTPs that come into that state and are willing to do business. So even now, I won't name names, but a state I can think of right now with about 3 or 4 million people has 6 methadone clinics. By comparison, we have 53 for 5.8 million. Not even close. And we need more. We think we need a ton more. If you're looking to say, hey, where can we grow? Certainly, we recognize that methadone is geographically locked for some people. It's really difficult to get in rural and frontier and frontier resort communities in our state. So we need to see expansion. We are seeing those applications come in for OTPs. Paul mentioned earlier that we have medication units now that we support officially in rural, allowing people to build out these satellite clinics with a lot less staff and allowing for telemedicine to occur so people can do that good work. But I would like to see realistically that we would double our OTP licenses in the next 3 years and maybe hopefully double or triple our census.
Great. Okay, ambitious goals from Ryan. Heard it here first. Okay, Andrew, take us home. What would you like to see?
All right. I have many requests, but I'm going to go with 2 miracle asks. My 2 miracle asks, one is a selfish one. I kind of mentioned how these policy changes are incredible, especially for newly induced patients, but for someone who's been on them for 10 years, it does very little. So I want, as the others on this call have asked for, more research and specifically into a pathway to graduate, phase out, or reclaim time and autonomy. Once you've been in the system for a certain amount of years, I think at a certain point, let us fly free. My other one is kind of living up to the billing of this panel. Patient voice is often included sporadically, inconsistently, informally, and without power. Advisory groups exist, but many patients experience them as symbolic rather than influential. And so I think that, Ryan and Paul and the many other researchers, physicians, professionals that have been so generous with their time with patients advocates like me, that is so amazing. But I want to make it embedded in the infrastructure instead of optional. And I know that there are certain, again, advisory groups placed in certain places and patient feedback is requested, but somewhere consolidated where we can have some power over the regulation changes in our own healthcare.
Excellent. Thank you. That's a nice place to conclude our panelist remarks. And now we're going to open it up for audience Q&A. So thank you all for still being here. I hope you found this conversation engaging. Please feel free to unmute and speak up and ask your question. Introduce yourself with your name and where you're calling from. Folks may chime in that way, or you may chime in via the chat. And Christy, I'm going to ask your help in sussing out the questions. Go for it.
All right, we have one in the chat already, asking, how do you balance expanding access to good quality care from unscrupulous actors who are not committed to patient-centered care?
I'm curious what Ryan has to say. I mean, I do think this is where having data, systematic, fairly real-time data can be helpful. And that data has to include, I think Andrew pointed out, has to include feedback mechanism from patients to hear what is actually happening on the ground. And to my knowledge, we don't have like a systematic way that we collect that information now, sort of across the state. And I think could be really helpful. But Ryan, I'm curious, from wearing your hat, how you balance that.
Well, it's important to say that from the state perspective, we have an obligation to monitor risk to the public and risk to recipients of care, and balancing that. And there are some pieces of data, and what we're talking about really are, diversion of medication, or another way I might say this is, for the longest time we sort of didn't trust the modality, we didn't trust the treatment, and we don't trust the patients, which I think it's not a great way to fly. And we built on that, and now we're trying to repair as best we can. However, we also want to make sure that we live in America and it's a for-profit healthcare system, and we want to be able to protect people, especially from the concept we all know too well of pill mills. And how do you create an environment where people are able to receive their medication safely, but also freely enough that it's not interfering with their life? And that is a very difficult balance. And you can talk to 10 providers, you're probably going to get 10 opinions. We talk to even peers and patients, and we got 10 opinions, and the stakeholdering process about where the rules should go. Talk to 10 different regulators, you're going to get 10 different opinions as well. So it is a real challenge. Some of the data that we use to track now are, we require all methadone clinics to report diversion of medication. And we also require them to report any overdoses or deaths that occur across their patient census. And we also work very closely with medical examiners' offices across our 64 counties in order to determine when someone comes in, has passed away from an overdose, is methadone involved, were they in treatment, were they not? These are forensic pieces of data. They're not super helpful at telling the larger story that Paul is alluding to. I think we need to build out a better conceptualization of how data can inform really truly how safe we are. And I will just add that we're always so focused on the harm side, which we should be, on clinics. But once someone drops out of care, they suddenly just become a statistic. I think not Paul, but Andrew said this earlier, that, okay, fine, you worry about the risk in this space, but once people leave treatments, that's risk too. It's risk to their lives when they can't access the treatment because you've made it too severe to enter into care. But how are we holding ourselves accountable to that harm being done? So I think we also need to equally weigh that. Very easy problems to solve, right, everyone?
All right, what other questions do we have?
Hi, everyone. I can ask a quick question. This is Mike Weiner. I'm a addiction provider in New York City, and I'm a big Paul Christine fan. And thank you for this call. I work in inpatient setting and in a methadone clinic, and I've worked with in 3 states, Massachusetts, Oregon, and now New York. And one thing I think is kind of nebulous to me as an addiction provider, even, is kind of around the SOTA. And so I was wondering, since we have a SOTA here, if Ryan, could you teach me like how does one become a SOTA? And two, until we have these like research databases, until we have these systems that we're kind of are on a wish list, I'm curious, like, how we can use the SOTA as a lever, as like one of the only unifying bodies that can like know what's going on in all of these different statewide OTPs. Otherwise, I feel like we're so siloed. So how can we leverage the SOTA and work with the SOTA um, to one, make sure we're doing equitable care and that these new changes are not only being enacted, but being enacted equitably.
Okay, another slow pitch down the middle, I guess there,
Yes.
Mike. Um,
And you only have like a minute or two.
okay. Well, I don't know how to speak to the how do you become a SOTA. I will say this: SAMHSA is a designated term from SAMHSA, requiring every state and territory in the United States to have one. So, depending on how that state is mapped out politically and structurally, that position will reside in whatever office they so deem. Some it's the Medicaid office, some it's behavioral health office. So that really sort of just depends state by state and who is a sucker that's willing to take that job. Now, I will say, how can this be helpful? First and foremost, recognizing that this position, it has the word authority in it, which is really uncomfortable because I am not an authority on this subject. I'm not the deepest subject matter expert, but I recognize that I have access to those who are. And so I think the job really is sort of the fascia between all of those entities. You're bringing in those in government that can help to move things forward with people that are subject matter experts and treatment providers in the field. We shouldn't be working against providers as I think we have in the past, sort of like these are bad actors that we all have to keep on a short leash. And really, they have the answers in terms of like informing us what is better practice. They have people who are receiving care that can speak to it. They have doctors who obviously are very aware of the research and can better inform our practice. So I think it's community building is ultimately the goal. We have meetings very often with our OTP providers to just sort of live and learn. How are things going? Let's talk about rules, but also let's talk about the state of things. What's the drug supply look like? What do people need in the community? If we were to ask for money from the federal government, where should that money go? And where should we expand next? So that's what I would say. The focus is really your building community.
Thanks, Ryan. Andrew, anything you want to add last minute to get you here in this Q&A?
No, just grateful to be here. I think it went great.
Okay. Well, that was like supposed to be a tee up for you to talk about the cab in Colorado, which we didn't really get a chance to talk much about. But in terms of something that Colorado has done that I think it feels somewhat rare and also could still be built out more. I think one thing we've learned in this call today is many things can be true at once, is that there have been intentional formations of patient-focused community advisory boards to inform decisions and many aspects of this process. And to your point earlier, Andrew, I think the more those voices can be not only at the table to provide input, but really to provide influence on what decisions are made and what steps are taken, uh, the better that we will see implementation roll out and the more patient-centered our practices will be.
I can
Okay,
get
well, we've reached the end of the hour. Thank you all so much for joining us. There's a lot going on in the world. So thank you for taking an hour to talk about methadone reform in Colorado. And everyone, we're coming to Denver to visit you and hang out soon. So thanks everyone. Have a great rest of your afternoon. We'll see you at the next AMERSA webinar.